अभी नहीं हो रहा है, पता नहीं क्या। So, very good afternoon to everybody. And today we're going to continue with our postgraduate lecture series, and we're going to focus about a very important topic of delayed puberty in girls. We had discussed in the last time. So this time we'll focus on delayed puberty in boys. So if we compare the overall etiology and the pathophysiology of both boys and girls, we will understand that delayed puberty is much more common in boys, but the likelihood of pathology is lower. So we need to be very careful in terms of not doing unnecessary workup in these scenarios, because that can cause more confusion from that perspective in regard. So what we'll do is that we'll use our scenario first of all in terms of pathophysiology to begin with. Then we'll talk about the etiological aspects of these disorders, and from there we'll focus about the overall assessment management. And then Dr. Sandeep has corrected a lot of questions which will really test out what we have been discussing throughout this program from that perspective. So just to set the stage of this lecture series, we'll start off with a couple of cases which will highlight the importance of rational evaluation of delayed puberty in boys. So this was a 13-and-a-half-year-old boy with delayed puberty who was referred with a testicular volume of just 3 ml and pubic hair stage 1. So parents were concerned that there is delayed puberty. He was relatively short for the family with a normal weight. On investigations, he had undetectable LH and testosterone. Now, based upon this, the treating physician made a diagnosis of hypogonadotropic hypogonadism and advised a MRI head. Now, this was a very troublesome situation because parents were really concerned about not only the short term, but also in terms of the long term future of the child, and also whether there could be a pathological cause in that perspective or not. Now, if we can look at this case very carefully, we'll see that this is too early age to evaluate for delayed puberty. He is probably going in more like a constitutional delay of puberty and growth, if at all anything. So this child should not have been worked up at all in this scenario. So I think this gives us an idea as to how so many cases where workup is not done, we are unnecessarily causing confusion in terms of evaluation. Contrary to that, we had this 16-year-old boy who presented with pubertal concern, who had an onset at 13 years. So puberty had started and then it stopped for 2-year period. At that point of time, when the child was seen by a physician, it was found that he had a testicular volume of 3 ml, which was soft. He had pubic hair development, which was a proof that there was a development to start off, and now the development has stopped. He was reasonably tall, and then he was labeled as constitutional delay of puberty and growth from that perspective. So this case scenario, in fact, if you look at it, there were everything which was going on, which was against the diagnosis of CDGP. This was a 16-year-old boy. Of course, there was the onset of puberty. The testes were there, and there was pubic hair development. The height was normal. So these are all against CDGP. So when we talk about that, we'll discuss about what are the pointers which go against CDGP. In this case, clearly developed and was found to have a brain tumor, which was causing these problems in that perspective. So this was a case in which we had missed the pathology. So in evaluation of puberty, which is a common scenario. 5% of all boys have delayed puberty. Physiological causes are common around 70% of cases. 30% have a pathology. What's important is that we do not do unnecessary workup in these 70% as was done in the first case, while we do not miss a pathology in the second case of 30%. This whole talk over the next 1 year, we'll discuss about the strategies about how to not do unnecessary workup while not missing on pathologies. All these resources are available in our website learning.growsociety.in, which offers a lot of resources as well as courses in pediatric endocrinology. We have our e-learning videos, so a lot of free stuff is also available over YouTube. There is option to look into our different courses, including fellowship courses in pediatric endocrinology and pediatric endocrinology for postgraduate courses as well. We frequently run grand rounds along with the PG lecture series and journal clubs to highlight these common scenarios. The books are available both online as well as the e-versions. Our app will help solve a lot of these problems. We'll try to see how it will help here. And today our focus is predominantly on delayed puberty in boys, in which myself and Dr. Sandeep will focus about the various aspects of delayed puberty from that regards. So just to touch base about pathophysiology, we know that the hypothalamic pituitary gonadal axis is the main controller of this axis. So we've got the GnRH, which is getting controlled via the stimulatory pathway, that is the KISS-KISS1 receptor, which in turn is regulated via the leptin. So when the body is at the right stage, it has got enough nutrition, the signal comes that, okay, this is the time now you can cross the toll bridge. So leptin is like a toll bridge. If leptin levels are low, you will not enter into puberty. But just because the leptin are high, you will also not enter into puberty. So you need to have all other things in place, and then leptin will be the final toll gate to decide whether you want to go ahead or not in that perspective. There are inhibitory pathways which include the neurokinin B and TAC3 receptor which regulate GnRH. So there is an active suppression of GnRH, which we discussed recently in our journal club, that this is actually established right when mini puberty is happening. So in the beginning, you have got the sudden surge in the levels of gonadotropin, and then the mini puberty surge sets in, which is inhibited. Now, this GnRH is then going to act on the FSH and LH. There is a common peptide regulating two important peptides, which then regulate the different parts of the testis. The FSH acts on the FSH receptor in the Sertoli cell to produce inhibin B and AMH, which are markers of Sertoli cell functions. These markers start to develop earlier. So they are early predictors in terms of testicular function. They may also be used as predictor of pubertal onset, which is there. LH acts on the LHCG receptor to act on the Leydig cell, and this is very, very important, and this produces testosterone. Now, we know that testosterone is very, very important between 8 to 12 weeks of gestation, because this is the time when there is the labioscrotal fusion. So if you have somebody who has testosterone deficiency, in the first 12 weeks of gestation, there will be atypical genitalia or hypospadia. Now, interestingly, HCG, which is coming from the placenta, will take care of this in the first 12 weeks. So you may have no pituitary, you may have no LH, or you may have a Kalaman syndrome, which is hypogonadotropic hypogonadism, yet the HCG will cover for the 12 weeks and avoid atypical genitalia in that regards. So individuals with hypogonadotropic hypogonadism present with micropenis and not hypospadia. So this is something which is very important, while individuals who have a problem in testosterone biosynthesis, testosterone activation or testosterone action will have both micropenis and hypospadias. Now, by the very nature of talk today, we'll focus predominantly on children who come to us with delayed puberty and not atypical genitalia. So we are mainly going to focus about those disorders from that perspective. Now, this testosterone is converted to dihydrotestosterone using the 5-alpha reductase, and then it acts via the androgen receptor. So the entire process is important. We'll talk about how steroidogenic defects in conversion of testo to DHT, and action of DHT will also result in delayed puberty in that regards. The Leydig cell also produces a very, very important peptide, which is insulin-like factor 3, which is primarily responsible for testicular descent in that regards. Now, GnRH is a primary regulator of reproduction, And that's why GnRH is extremely important from a species perspective for development. So the very important process which happens in terms of GnRH neuronal development and position is its migration. So GnRH neurons are actually developed via neural and ectodermal origin along the area of olfactory placode. So they do not develop in the hypothalamus, they are developed in the olfactory placode, and from there they have to migrate. And this migration process is very, very long. It involves a number of genetic factors. You can see multiple genes are involved. Once they come in that region, a very critical gene known as enosmin-1, which we know as CAL1 also, which is responsible for Kalaman syndrome, is there. And from there, multiple other factors are there. So what we can see that this migration of GnRH neuron from the olfactory placode to hypothalamus is regulated by multiple genes. What does it mean? It basically means that it is extremely crucial for the body from a reproductive perspective. That is why you've got so many genes, which explains that many of these disorders will not have a classical Mendelian inheritance, and they may be oligogenic inheritance, in which many genes are required to be damaged before you go ahead to develop hypogonadism from that regards. Now, once they come in the brain, the GnRH neuron will go towards the hypothalamus and the olfactory neuron will go towards the olfactory bulb. So, absent olfactory bulb along with anosmia is a very, very important sign which tells us that there is a problem in GnRH migration. So, any boy who comes to you with delayed puberty, the first question you should ask is whether the smell sensation is normal or not, and you will get the idea here right away. Now, there are other neuronal migration defects which may happen along this pathway, which may result in other subtle features like there could be a problem in terms of the symmetrical movements which are there in the body. There could be synkinesia, in which they have abnormal movement which is happening. There could be other features which are subtle features of hypogonadotropic hypogonadism and Kalaman syndrome, which we'll talk about subsequently. Now, this whole process is completed by 15 weeks. And that's why the role of HCG becomes important. Because by 15 weeks, you've got no GnRH, no LH, no testo. So where does the testo come from? It comes from the HCG, and that prevents the development of hypospadia in hypogonadotropic hypogonadism. Now, there are around 10,000 GnRH neurons which are migrating, and you don't need 100% of them. Even if you have 12 to 15%, they may be sufficient. And this forms the basis of a confusing picture of what we say constitutional delay of puberty and growth versus hypogonadotropic hypogonadism. Now, maybe a couple of decades ago, people said that, okay, there are two distinct conditions. One in which you do not have development at all and you will not develop, that is permanent HH. The other condition in which development will happen later on and you will progress from there, which is a constitutional delay of puberty and growth. Now the data suggests that these are not two distinct conditions, but they are actually the spectrum of the same disorder. So the mildest form of hypogonadotropic hypogonadism and the severest form of CDGP may actually overlap. And there may be some genetic defects which are there, which are responsible for both CDGP as well as permanent HH, and that depends upon how they are expressing. What are the other factors which will decide about the phenotype? One simple way of understanding is that, okay, 12 to 25% is sufficient. If you have got 15-20%, maybe you will have later onset of puberty. And then what will happen is that you will progress from there. But if the numbers are very less, you will not enter into puberty. This also explains that many CDGP, whom we label CDGP, progress and then stop. Because maybe their neurons were very less, they had some initial development, then they stopped. So this CDGP may migrate to permanent HH. And on the other hand, we have seen individuals who had quote unquote permanent HH. We gave them testosterone and after some time testicular volume increased. And that was suggested that, okay, they are going to progress. So don't consider CDGP and permanent HS as two watertight compartments. There may be some overlap which is there also in that regards. Now, gonadotropin levels, which we have discussed also in the case of girls, we know that both LH and FSH rise with puberty but the rise of LH is much more. It's around 10 times as compared to the delta rise in the setting of FSH. So if you want to look at one sign of pubertal onset, LH will be a much better picture. However, if you are looking at a sign of gonadal failure, FSH becomes important because inhibin deficiency is more likely to happen earlier, and that's going to cause your high levels of FSH. So LH is a marker of hypogonadotropic hypogonadism, and FSH is a marker of hypergonadotropic hypogonadism. So generally, with the newer chemiluminescence, we can easily identify between these conditions, and if required, we give GnRH analog, which are not very commonly given. If levels go above 5 milliunits per liter, it indicates that there is enough reserve and puberty is imminent from that regards. We should also understand the testosterone levels, and these are the most common tests we do once a child comes to us with delayed puberty. Check the testosterone level and then interpret it. We need to understand that testosterone depends upon the pubertal stage as well as the age. So at pre-pubertal stage, testosterone should be undetectable. People say 20 nanogram per ml as a marker, but usually you can say it will be undetectable. As the level increase, your level should increase. So whenever you're looking at testicular volume, try to see whether it is correlating with testosterone. If you have a large testis, but the testosterone levels are not that high, it would mean that there may be just Sertoli cells which have grown. Classical case will be hypothyroidism, in which you can have, and there is a correlation as levels go, maybe around typically 10 to 15, you start having levels pretty much into 150 adult sort of a range from that perspective. Remember, at lower level, the assays are not made to detect your testosterone at 20. They are made to detect testosterone as 100 to 200. So the enzyme assay based techniques or immunoassay based techniques are unreliable. If you want to really assess proper levels of testosterone in peripubertal boys, it should be a GCMS based assay in that regards. Testosterone is known to have fluctuations, so a pooled sample is required, and the levels are highest in the setting of early morning because your LH surges start happening at night. So testosterone starts peaking in the morning. So morning levels are ideally recommended in early puberty. If levels are low in early morning, it indicates that it is a less likely chance of puberty. But testosterone clearly is a late feature of delayed puberty, and there are other earlier more sensitive markers like LH, GnRH stimulation test, and most importantly inhibin B, which I'll be talking about, which will tell you much earlier whether the puberty is imminent or not. Now, in this context of these three organs, hypothalamus, pituitary, and gonad, and three hormones, GnRH, gonadotropins, and androgens, we can consider the possible causes of delayed puberty. It could be hypogonadotropic, in which, of course, the LH and FSH are low. The problem is in the hypothalamus or pituitary, or hypergonadotropic hypogonadism, in which the problem is predominantly in the gonadal level. You have high levels of LH and FSH. The elephant in the room, as far as the delayed puberty is concerned, is constitutional delay of puberty and growth, and it's the duty of the physician to not miss it and don't unnecessarily work up in that regards. Any systemic disorder will affect the hypothalamus through the leptin pathway. So leptin, kisspeptin will be low. Your GnRH will also be low. Other problems will include isolated defects, multiple pituitary hormone deficiency, any insult, trauma, surgery, radiation, infiltration can be there. The classical problems in hypogonadotropic hypogonadism may be testicular dysgenesis, Klinefelter syndrome, again is a very important cause, insult to the testis, receptor defect, steroidogenic defects, and all those scenarios will be there. Classically, complete deficiency of testosterone or testosterone action will cause atypical genitalia and not really delayed puberty. However, milder defects may present you with delayed puberty or maybe some small hypospadia which is missed in that regards. A major difference between hypogonadotropic and hypergonadotropic hypogonadism is the gynecomastia, which is substantially more in the setting of hypergonadotropic hypogonadism in that regard. So now I'll hand over to Dr. Sandeep, who will now discuss about etiopathogenesis of delayed puberty.
Thanks. Thank you, Rus. Good afternoon, everyone. we are going to discuss about the etiology of delayed puberty in boys. As Sir has already discussed, if there is no pubertal development by the age of after the age of 14 years, then we should concern and we should then investigate. Investigating before the age of 14 years lead to unnecessary investigations and also parental anxiety. So broadly, etiologically, delayed puberty in boys is broadly classified into two groups. First is hypogonadism, in which the LH-FSH levels will be low, and it will involve hypothalamus and pituitary. Second group is hypogonadism, in which the defect is at the level of testis, and the LH-FSH level will be high. So the most important cause, 70% cases are assigned in physiological or self-limited, also known as CDGP. In the pathological causes, we have 10% cases of hypogonadism due to testicular dysgenesis, skeletal syndrome, torsion, insult, and stereogenic defects. In hypogonadism, we have 10% functional cases due to malnutrition, systemic illnesses, hyperprolactinemia. 10% permanent causes in which we have multiple pituitary hormone deficiency due to genetic insults or acquired insult and infections. And we have isolated GNRS deficiency due to various genetic defect like KIS1 GNRS defect, CAL1 defect, FGR defect. In the physiological causes, in the functional causes, in MPSD, there will be short stature and there will be no pubarchy. However, in case of isolated GNRS deficiency and hypogonadism, there will be pubarchy. Apart from this, in hypogonadism, there will be low LH-FSH, and in hypogonadism, there will be high FHS to start with, and later on there will be high LH. So this is we will now discuss about self-limited delayed puberty, which is like most common, and 70% cases are assigned. It is usually familial and like it is autosomal dominant, and usually it is associated in 50 to 75% of the cases and can be inherited from any of the parent. In this, we have a suppression of GNRS axis, due to which we have low LH-FHS level, and which will lead to low testosterone. Usually, morning testosterone is less than 20. But the inhibin B, as already discussed, it will start rising before the puberty, and in this scenario, it will be usually more than 35. These cases usually have antenatal exposure of GNRS to the gonadotropes, so they will respond to the GNRS stimulation test, and the GNRS stimulated LH will be more than 5, and HCG stimulated testosterone will be more than 200. A trial of testosterone can be given, and they usually respond after 3 to 6 months of testosterone, and there will be a progression of puberty. It is usually self-limited, and there is usually they subside by the age of 18 years. They have effect on growth. Initially, there will be growth delay, there will be a delayed bone age, and they also have psychosocial impact. The treatment is observation, and in selected cases, we give a testosterone course of 50 to 100 mg per month for 3 to 6 months, which will lead to progression of puberty. As already discussed by Sir, GNRS neurons are developed along with olfactory neurons by the age of 5 to 6 weeks in olfactory placode, and subsequently they are migrated to hypothalamus by the around 12 weeks of gestation. So there are various genes involved in this migration, and the defects in these genes can lead to GNS deficiency, along with there can be variable anosmia. Very important is anosmin 1. Apart from that, we have CDH7, FGFR1, we have IGS10, PROC-K2. They have variable anosmia, and they present with isolated GNRS deficiency. Importantly, anosmin 1 defect, also known as CAL1 defect, it leads to X-linked congenital hypogonadism, also known as Kallmann syndrome. In this, there is defective migration of the GNRS neurons. It is severe, variable. It will lead to, in neonatal period, there will be micropenis, cryptorchidism, there will be anosmia, cleft lip, cleft palate, there will be teeth hypoplasia, synkinestic movement will be there, ptosis, hearing abnormalities can be there. Apart from this, there can be renal agenesis, dental anomalies, and it is rarely reversible. Other important causes in the migration defects, we have CSD7 defect, also known as Char syndrome, which stands for coloboma of eyes. We have heart defects, corneal atresia, retardation of growth and puberty, genitourinary abnormalities, and ear hearing defects. It is due to CSD7 defect, and as already discussed, coloboma of eye, hearing defect, dysphagia, cardiac defects, cleft lip, cleft palate, corneal atresia, urinary tract abnormalities, tracheoesophageal fistula can be there. There are few genes which are involved in the regulation of generous neurons like KIS1, KIS15, KIS1 receptor, TAC3 receptor, GNRS receptor. All this lead to non-syndromic causes of GNRS deficiency. Apart from this, we have leptin and leptin receptor, which will lead to obesity. So briefly about the summary of genetic causes of isolated congenital hypogonadotropic hypogonadism. Anosmia 1, which is X-linked, there is anosmia is present and there is no reversibility. Presents with synkinesia, hearing loss, and renal defects. FGFR1 presents with skeletal abnormalities. There will be hearing loss, synkinesia, and it is reversible. CDH7 presents with CHART syndrome. DAX1 presents with congenital adrenal hypoplasia and hypogonadism. GnRH receptor, KIS1 receptor, TAC3, they are usually causes of non-syndromic isolated GnRH deficiency, and leptin receptor present with obesity and hyperphagia. Genetic MPHD is again one of the important cause. We have various genes like HSX1, which is involved in the early embryogenesis. It will lead to subtoptic dysplasia. PROP1, it presents with growth hormone, TSH, and prolactin deficiency, and later on GnRH deficiency. POW1, F1 presents with growth hormone and GnRH deficiency. LHX3 presents with spine defects. Functional GnRH deficiency is again very important cause, and we should rule out this before going to extensive endocrine investigations. Malnutrition, anorexia, systemic diseases like celiac, renal disease, liver disease, infections like chronic infection, tuberculosis, endocrinopathies like hypothyroidism, Cushing syndrome, type 1 diabetes. All this lead to low leptin levels, and there will be a suppression of GnRH axis. So eventually there is low LH-FHS, and which will lead to low testosterone, delayed puberty. These patients usually have poor growth. There is a lack of puberty, and we should do a systemic workup and make the diagnosis. Importantly, they are different from CDGP because they look more ill than the CDGP patients, and we would correct the underlying cause before going for extensive endocrine investigations. There are various obesity-related syndromes which are associated with the GnRH deficiency, like Prader-Willi syndrome. We have in this hyperphagia, obesity, acromicra, and almond-shaped eyes. Lauren-Bartle-Biddle syndrome, we have polydactyly and renal anomalies. Alstom syndrome, we have eye defects. CHART syndrome is a spectrum, and Robinow presents with cardiac defects. Mass lesion can lead to acquired GnRH deficiency, and it usually presents with stalled puberty and pressure effects. Various causes are like macroadenoma, stalk thickening, rhinopharyngioma, pituitary cyst, rat case cyst, and germinoma. In such cases, MRI head is warranted. Radiation has a variable effect. In low doses, there is suppression, there is interruption of the inhibitory signals, and it will cause early puberty. And in high doses, there will be destruction of the gonadotropes, which will lead to delayed puberty. Infiltrative disorders which present with stalk thickening, sarcoidosis will have rash, nodule, there will be hypercalcemia. Histiocytosis will have rash, seborrhea, there will be diabetes insipidus, and autoimmune hyperphagitis usually presents with headache, mass effect, and early acidic involvement. Very important is Klinefelter syndrome, which is one of the most common causes in hypergonadotropic hypogonadism. It presents with initial pubertal development, and there is an arrest at a later stage. The patient will be tall, there will be a large arm span, there will be large legs, and many patients will have gynecomastia at presentation. There will be small, firm, and shorty testes. There will be a small phallic size. It is usually associated with mediastinal HCG producing tumors, type 2 diabetes, CA breast, and cardiovascular diseases. It is diagnosed with the help of karyotype, where we will find an extra X chromosome, and most common karyotype is 47XXY. Incidence is 1 in 667 male births, and treatment is testicular extraction of sperm and then intracytoplasmic implantation. Biosynthetic defects are very important. In the milder form, they present with delayed puberty. The DSC7 defect Smith-Lemli-Opitz syndrome presents with salt wasting and there will be syndactyly. SSC and star defect presents with salt wasting and it is usually severe. 3-beta hydroxysteroid dehydrogenase defect presents with salt wasting and DSD. Milder variants will present with delayed puberty. 7-hydroxylase deficiency usually present with hypertension. And 17-beta hydroxylase steroid dehydrogenase defect presents with delayed puberty. There will be sex reversal and milder form they will have delayed puberty. A summary of steroidogenic defects with XY-DSD. DSC7 present with syndactyly and salt wasting. There will be low cholesterol levels. Star and side chain cleavage defects present with salt wasting. There will be low metabolites. 3-beta HSD defects present with salt wasting. There will be high pregnenolone levels. 17 hydroxylase defect will present with high hypertension. There will be high DOC levels. 3-beta hydroxysteroid dehydrogenase 3 defects presents with complete reversal. There will be high androstenedione to testosterone levels. P450 oxidative defect presents with salt wasting and there will be high 17-OHP levels. Androgen testosterone is converted to dihydrotestosterone by 5-alpha reductase 2 and which subsequently acts on the androgen receptor to cause the effect. So if there is a defect in the 5-alpha reductase 2, there will be defect in the testicular activation. The testo to DST ratio will be more than 10. At puberty, this excess testosterone will cause virilization and the gender of rearing will be male. Mullary structure are absent and management is with high dose of testosterone and local application of DST gel. In complete AI syndrome, there will be defect at the testicular action at the level of androgen receptors. So DST level will be high. The testo to DST ratio will be less than 10. At puberty, this testosterone will get converted to aromatized to estrogen and will cause feminization. Gender of rearing is likely female. Absent Mullerian structures, treatment is with gonectomy and further estrogen therapy. Cancer has various effects. It affects the germ cell, it affects Leydig cells, it affects the spermatogenesis. It will lead to small testicular size and alkalizing agents like cyclophosphamide in a dose of 200 mg per kg will lead to testicular failure. The assessment is done with testosterone, LH, semen analysis, and treatment remains testosterone. Thank you, sir.
Thank you, Dr. Sandeep, for really summarizing the entire etiology, and that makes my life much easier in terms of how do we assess from that perspective. We'll have a look if there are any questions which are there at the moment. So there are no questions. We'll continue with the assessment. Just a word about cancer. So basically what we're trying to say is that there is a differential effect of radiation on the Leydig cell and the Sertoli cell. So germ cells are affected at much lower, 0.5 grays, while Leydig cells may be preserved. So these children will have delayed puberty, but they will more likely to be sterile. So this is something we have to consider, that just puberty does not mean that they will be fertile. That's why we talked about semen analysis at a young adult age group. Now, the three questions which a physician has to answer when they are managing a child with delayed puberty is it really delayed puberty? If it is delayed, is it physiological or pathological? And finally, what is the cause? So delayed puberty in boys is again a statistical definition. If there is no testicular enlargement by around 14 years, which is around 2.5 standard deviation score from mean, or there is a stalled development, we call it a delayed puberty. Importantly, do not consider penile size in delayed puberty because penile size assessment is difficult. The references are not really based upon large data. So we don't use that. And pubic hair, of course, is a different ballgame altogether. That is coming from the adrenal. So we don't really know whether it's going to be significant or not in that regards. The second question is it physiological or pathological? And that's the crux of evaluation because as we discussed, 70% of them are physiological. You don't want to do unnecessary workup in that regards. So when you are looking at, I think the primary role of an endocrinologist would be to think that this is not CDGP. And even a pediatrician will also be there because there you want to work up, you don't want to miss. So as Dr. Sandeep has clearly said, that children with CDGP generally tend to be on the shorter side. They do not have a pubic hair development. They have a delayed bone age. They don't have a pubertal onset. So if somebody already has pubarchy, somebody has a normal growth, puberty started and then stopped. There is a stalled puberty And if, of course, there's a micropenis history, you are not dealing with CDGP. And this could be a sinister pathology. This is what was the second case I talked about, a boy who presented with normal height, pubic hair development, stalled puberty, and was labeled as CDGP, but turned out to be a craniopharyngioma. So we have to be very cautious in that regards. So we already discussed this about what CGGP is all about. The options to evaluate, of course, clinically are there, but also we can look at various other clues for diagnosis. So if there is a strong family history, particularly of delayed growth in parents, this could be both father or mother. This is an autosomal dominant condition, so can affect both. So delayed onset of menarche, continued growth of father during college years, delayed shaving, all these parameters are there. Other tests include the use of GnRH stimulation test or HCG stimulation test, inhibin B, and testosterone. Now, inhibin B is a good marker in terms of predictor as far as puberty is concerned. We'll touch base a bit when we talk about biochemical evaluation. So, if you have a child who has retarded growth and bone age, there are no pubic hairs, testicular volume is more than 1 ml. Typically, GnRH stimulation test has a LH more than 5, and you have got a detectable inhibin and a testosterone, then you can clearly say this is CDGP. However, if somebody is not short, has got some pubic hair development, testis is very small and soft, and there is blunted response to GnRH, low levels of testo and inhibin B, it is more likely to be permanent HH. However, the gold standard in terms of differentiating the CDGP or self-limited delayed puberty, which will be a more appropriate term. Remember, 10% of boys with quote-unquote CDGP have normal height. So the term of growth failure may not be appropriate. That's why we use self-limited delayed puberty. And permanent HH is actually how do they do on follow-up till around 18 years of age. So you cannot wait to that time. That's why you want to do all these workup to identify from that perspective. The next question is, once you know that this is a pathological cause, then you want to know what is the underlying pathology. For that, again, as we've always been focusing, clinical examination will give you a clue. If you have a large testis which is not producing testosterone, as I said already, which means Sertoli cells are more, classical picture is hypothyroidism. If, however, you have got small and soft testes, this is classically GnRH deficiency. You have got some enlargement, but not big enough, that is constitutional delay of puberty and growth. If there are small and hard testes, that could be Klinefelter syndrome. And rarely, we have seen a few cases of late which are anorchia, in which they had some development to begin with, and then testes are lost either in the fetal period or in the early childhood period, they will behave like that. So the most important thing to look at is testicular volume. And second, of course, is the pubic hair. So if you correlate your testicular volume and pubic hair, I discussed this about in girls with delayed puberty, equally important in boys with delayed puberty as well. So if you have a small testis but good pubic hair, it means adrenals are working fine. This is GnRH deficiency. If you, however, have a slightly bigger testis with no pubic hair, which means it's most likely CDGP or illness. A child who is sick in this scenario will have a systemic illness. Otherwise, your diagnosis will be CDGP. If the testis is big, but there is no pubic hair development, this is classically hypothyroidism. And if you have got a child who has not that much testicular development, but a lot of pubarchy, this is what we see very often in obesity. So obesity is an interesting phenomena. Obesity will cause early adrenarche because of insulin resistance and advanced bone age. There may be delayed puberty in terms of gonadarchy because of high estrogen levels. Your fat is more, the fat contains aromatase, estrogen is more, it suppresses the LH-FSH, and that's why you will have a blunted gonadarchy and an accelerated adrenarche causing this sort of a picture. So looking at testicular volume and the pubic hair will give you real clue in terms of diagnosis. Now, you can always look at other clues. So if somebody is really obese, there is hyperphagia, think of Lawrence bone beetle, Prader-Willi, Alstrom. Already Dr. Sandeep had talked about that. If somebody is very short, think of multiple pituitary hormone deficiency or a systemic illness. Polydactyly may happen with Bardet-Biedl syndrome, and anosmia can happen with Kallmann syndrome. So the very important thing to ask is whether you can smell. There are definite tests also which are available for that. The presence of hypertension in this scenario suggests that there could be a biosensitive defect in the 17-hydroxylase region. As I said, we are not focusing about atypical genitalia, but if there is hypospadia, that means that the hypogonadotropic hypogonadism is extremely unlikely. You're dealing with a testosterone biosynthetic defect, steroidogenic defects, or action of testosterone is defective. What about hormonal assessment? So if you can see, the testosterone levels will rise immediately and then they will fall. And these levels will remain very low throughout your childhood to rise again during puberty. So in the prepubertal age group, testosterone is totally useless as a test. During that stage, AMH is a good marker. This is very, very high. So in this scenario, you can use AMH if you want to confirm that there is an abdominal testis, especially in the setting of somebody you are thinking of anorexia. However, what you see is that before your testosterone rises, there is a rise of inhibin B. AMH has gone down. So this time inhibin B is the best test. So inhibin B will predict the development of puberty maybe 6 to 12 months before your rise of testosterone. That is why if you ask me one test which is very, very helpful in this regards, it is inhibin B. If you combine testicular volume with inhibin B, you will get the clear picture in most cases, and that's something which is extremely important. So for very early prepubertal age group, AMH is good. Subsequently, you can use inhibin B. Testosterone is not a good marker. HCG stimulation test is something which can give you an idea, but we don't use that very, very often in that perspective. Now, whenever you are measuring testosterone, you have to correlate testosterone with LH levels. There is a log linear relationship between testosterone and LH. If your testosterone is low, LH should be sky high. So if your testosterone is low and LH is not high, so even if it is normal, this is hypogonadotropic hypogonadism. If your LH level is extremely high, it basically means it's a primary hypergonadotropic hypogonadism. There could be rare scenarios in which your testosterone is high and still the child has delayed puberty. In this scenario, if your LH is also high, means testo high, LH high, basically means testo is not working. So this is androgen insensitivity syndrome. And if you have got a low LH with high testo, it means there is an exogenous testosterone which was given, which can cause this picture. So often boys will go to some person, quack or something, they will give them testosterone. So there is some development, you don't really know whether there is a delayed puberty or not, and you get the report, you say, okay, LH is very low and testo is high. What is the cause? They have given the injection, just like the exogenous steroids, which are often given in these scenarios in that regards. So just to summarize on our flow chart, start off first with screening test. Do not do anything unless you have proven that there is no liver disease, kidney disease, thyroid, celiac, all those things are ruled out. Then if your gonadotropin is high, you're mostly dealing with hypergonadotropic hypogonadism. 99% testosterone will be low, do a karyotype. This is your typical Klinefelter syndrome. If, however, rarely your testosterone is high, you may have a androgen insensitivity syndrome, do a DHT. If it's low, it is 5-alpha problem, or otherwise it's androgen insensitivity. The confusion happens usually on the right side of the algorithm. If your gonadotropin is low, you may have a CDGP, you may have a systemic illness, you may have a permanent hypogonadotropic hypogonadism. You would, of course, have already excluded a lot of systemic disorders by now. So then you ask for pointers of hypogonadotropic hypogonadism. So if you have a boy who has got micropenis, undescended testis, anosmia, synkinesia, CNS features, and a low LH, don't need to worry much. This is permanent hypogonadotropic hypogonadism. Consider MRI and other tests as well. In the absence of this, look at testicular volume. If testicular volume is more than 3 ml or 3 ml or something like that, it means that you're pretty much entering puberty. If it's less than 1 ml, then it becomes difficult. In that case, you do an inhibin B. If it's low, this is permanent HH. If inhibin B is high, or if the TV is more and inhibin B is more than 100, this is diagnostic of CDGP. On the other hand, if you have got a testicular volume less than 1 and inhibin B more than 50, or a TB more than 1 and an inhibin less than 100, then you can do a GnRH stimulation test to classify into a permanent HH or hypogonadotropic hypogonadism because of a constitutional delay of puberty in growth. So if you look at the algorithm, this may look confusing, but simply do the screening test first. High levels of FSH, do a karyotype. That is very simple. If the LH-FSH is low, then you start thinking of permanent HH. Look for clinical features, absent, very small testis, get a inhibin B low, this is permanent HH. If its testicular volume of 3 ml, inhibin B is high, that is CDGP, in between do a GnRH stimulated test. So we are not giving that much importance to the basal testosterone. We're not giving that much importance to HCG stimulation test, and in most cases you will get the right diagnosis using this algorithm. So we have now 14.5-year-old boy with delayed puberty. Family history there in father, height is 148, weight is 45, testicular volume is 2 ml, pubic hair is stage 1. So Dr. Sandeep, what are you thinking of? So you have a short child who has a small testis and no pubic hair. Yeah. So this is fitting into CDGP. Screening tests were done, which was normal. There were no pointers to HH. Testicular volume is already 2 ml, more than 1. Inhibin B is 125. So this is classically you're dealing with a case of CDGP. Second scenario, 15-year-old boy with delayed puberty has a small phallic size at birth. He is not short for the family. Weight is normal. Testicular volume is 1 ml soft. So how is he different from the previous case?
First of all, small phallic size against CDGP, and this height is again against CDGP, and the testicular volume 1 ml is again.
So this is just subtle differences, but they will give you a good enough clue. He also has stage 3 pubic hair. So there is everything written that this is not CDGP. Micropenis, normal height, very small testis and pubic hair, which basically mean that you are dealing most likely with a permanent HH. There were no pointers of HH. Inhibin B was low. So then you make a diagnosis, this is permanent HH, and then you can do further evaluation. This case I've already discussed, that 16-year-old boy who had an onset at 13 years, stopped for 2 years, small testis, pubic hair is there, and labeled as CDGP, but this was actually a large lesion which was sitting there. So don't be very scared of stalled puberty. That is worse as compared to delayed puberty. 16-year-old boy with delayed puberty, testicular volume is again 3 ml, no pubic hair, very, very short. And the weight is also less. Bone age is delayed. He has low LH, low FSH and testosterone, labeled as hypogonadotropic hypogonadism, advised MRI head. Do you agree? Yes. So this, yeah. So this could be a multiple pituitary hormone deficiency. It cannot just be a simple hypo, or this could be a systemic illness. So in this case, he had anemia and celiac has to be considered in this scenario. 15-year-old boy with delayed puberty had micropenis. Height is 162, testicular volume. This I think we already discussed about that. If we just compare this table, we will find that there are classical features that the bone age is 14 years, which goes against CDGP, and this is likely HH. And the workup basically showed a low testosterone and no response, and there is anosmia. So now, which genetic defects are out if there is anosmia? So this will be post-migrational will be out. So something like KISS receptor, KISS1 receptor, GnRH receptor, you're thinking of either an anosmin defect, FGFR1 or CGH, CHD7, all these things could be likely in that regards. Now in this regards, you can then plan thinking of giving testosterone in this case, and with testosterone, they will improve, but the testicular volume is not increasing. So this is expected. This is a permanent HH in that regards. 14-year-old boy with delayed puberty, testicular volume is 1 ml, pubic hair stage 3, height is 142 centimeters. So he is short in that regard, but he is very obese. And LH FSH is low, pubic hair is there. So what do you think? So this is because of obesity, differential effects on gonadarchy and adrenarchy. So your DHEAS is good enough, and that's why there is development. But the other feature is that he is very obese. Delayed puberty is hardly anything for 14 years. What is more concerning is weight of 82 kgs. So there is hyperphagia. So you have to think of a Prader-Willi as a possibility as well. 17-year-old boy with pubertal concern, he had an onset at 12 years, but now since 3 years, he doesn't have any development. There is firm 2 ml testis with gynecomastia. What do you think is this clinical picture?
The stall puberty, sir. The form small testis with gynecomastia points towards Klinefelter syndrome.
So this is a classical case of Klinefelter. You have got a high LH FSH, testosterone is low. So this is Klinefelter syndrome, as you already discussed. 15-year-old boy with delayed puberty, there is a history of penoscrotal hypospadia surgery. So this is even worse than micropenis. So there is something going on. Penile length now is 7, pubic hair is stage 4. There are inguinal testes which are there. What do you think is happening?
There was a history of penoscrotal hypospadia at birth. So there is defect in the testicular action or testicular convergence.
Synthesis, action, conversion. So all those things can be there. LH and FSH are high. Testo is also high.
Testo is high, then we have to look for the DST levels.
Yes, so DHT was suggestive of partial AIS. So you've got a high testo, high LH, which means androgen insensitivity. So we have developed a puberty interpreter which helps in terms of evaluation of both delayed, precocious in both boys and girls. And this has been found to be effective. You can use it. The tool is available online and this can be effective. So we have covered a lot in terms of pathophysiology, etiology, evaluation. We'll focus a bit about management here. So the option that we have is, of course, to give testosterone. That's the end organ. We give testosterone. This will work in both hypo and hypergonadotropic hypogonadism. However, there is a growing consensus, especially in the developed world, that maybe giving gonadotropins will be a more physiological way of inducing puberty in this regards. And in fact, teams in Europe have started giving gonadotropins right in the mini puberty. So if they are able to pick up hypogonadotropic hypogonadism at that age group with micropenis, maybe with multiple pituitary hormone deficiency, they do a FLH, FSH at that time, because that may theoretically help in terms of fertility. There is, however, no clear-cut evidence in terms of long-term outcome, and we have seen patients who have most severe form of Kalaman syndrome who will respond very well to gonadotropin therapy. So this is something which can be considered as a experimental therapy in that regards. There are certain GnRH pumps which are also available which use pulsatile GnRH, and there are work on kisspeptin which is going on. So the most common agent, of course, is testosterone. The one which we use most commonly is testosterone enanthate, which has to be given intramuscularly. Start off with a low dose, 50 milligram around 12-13 years of age, and then try to build up around 100 milligram. And the adult dose is 100 milligram every week, and we give it 3 weekly. It's a long-acting preparation which gives 1000 milligrams over a 12-week period. It is not recommended for pubertal induction. Its main role is once every pubertal induction is done, you want to give less frequent dosing with less fluctuation, more stable levels. Then this preparation in the form of Serenos Depot is what it's named as, is available, can be used. Gel is available, but it is having variable onset. It is not a very effective therapy for pubertal induction. Oral medications again have an issue in terms of hepatotoxicity. So what we focus mainly is to start off with this 100 milligram injection and go forward to the 1000 milligrams once things become progressive in that regards. For CDGP, we give a course of testosterone for 3 to 6 months. Usually the testicular volume increases in that regards. For permanent, we will be giving starting with 50 and then try to build it up over a 2-year period. So just like girls, where we start with around 10% of estrogen dose to build up around 2 to 3 years. Similarly, in boys, we start around roughly 15% of dose and then try to build it up over a 3-year period in that regards. Fertility is possible in hypogonadotropic hypogonadism with a combination of both LH and FSH, which could be HCG and HMG, or recombinant forms. For hypergonadotropic hypogonadism, it's less likely, extremely less likely to be more precise. If there are some sperms which are present using TISA, you can then get those sperms, extraction of sperms, and then you can use it from that regards. So hypogonadotropic hypogonadism management depends upon how the child presents to you. If there is micropenis, we give a course of testosterone 25 milligrams, 3 doses, and start puberty around induction time of 12 years. Gonadotropin have been used for fertility for quite some time, but people have also used them now for delayed puberty treatment. And as I said, in Europe, they're also using it for mini puberty as well. Remember, the use of testosterone will cause increase in pubic hair growth, but the curling of pubic hair does not happen without gonadotropin. The testicular volume increases only with gonadotropin. If a boy has an increase in testicular volume with testosterone, think of a self-limited form of delayed puberty or a reversible form of hypogonadotropic hypogonadism. So infancy, you're mainly dealing with cryptorchidism or micropenis. You give testosterone 25 milligrams for 3 doses. Cryptorchidism surgery, as we discussed, is the treatment of choice. For self-limited delayed puberty, start at around 14 years of age and bone age of 13. Start with 50 to 100 milligram per month, 3 to 6 injections, then wait as to how things are progressing. So if you have a boy who has come to you with delayed puberty, consider treatment at around 14 years and bone age of 13. Give testosterone 100 milligram monthly for 3 doses. There is a response, you basically get that nothing much needs to be done. No response, give another course. If the testosterone levels remain above 100 on follow-up, this is a good response. However, despite second course, there is no response, you are thinking of a permanent HH. Don't be dogmatic that this is only CDGP, this cannot be permanent HH in that regards. For permanent HH, if you already know, you can start a bit early. Like in Turners, we say if you know Turners, you can start at 12, start around 12 years of age, start with a very low dose, maybe 25 to 50, because they have never received testosterone in their lives. So the only scenario in which I have seen a very severe effect of testosterone in the form of priapism is ones who had these permanent HH because they did not have any testosterone during their late fetal period, during their mini puberty. So if you give them testosterone, they may develop priapism. So just as we say that for severe GHD, start with low dose, for severe hypogonadotropic hypogonadism, start with a low dose of testosterone. An adult dose by around 3 years. If the testis size increases, this suggests that there could be a reversible form, and we monitor using a trough level of testosterone. You expect a phallic size increase. There is no increase in testicular volume in that perspective. And as I said, curling of pubic hair requires your gonadotropin and not just testosterone. The options of fertility are you can use GnRH pump, which is not readily available. You can use HCG and HMG, which are surrogates for LH and FSH, and you give them for around twice a week. You expect sperm formation by 6 months, pregnancy by 12 months in approximately 70 to 80% of these cases. However, if somebody had a very early onset, complete form, and previous treatment of testosterone may have some negative implications in terms of achievement of fertility. For hypergonadotropic hypogonadism, start around 14 years and bone age of 13 years. Start with testosterone, and like any other patient, you build up, look for growth, bone density, and fertility. The option could be TISA in that regard. So we have tried to cover the entirety. We'll take a couple of questions which are there, and then we will head towards the very interesting part of OSCE. So there are few questions there. Dr. Kamalhasan is asking, normal testis is sperm. In some hypogonadism, it will be firm and some soft. Why and where? So if you have a soft testis, it is more likely to be Kallmann syndrome. While if it's hard, it's more likely to be hypergonadotropic hypogonadism. So you confirm testicular volume using a orchidometer, you compare that. Dr. Adelaide is asking, a 14-year-old boy diagnosed celiac disease, has delayed puberty, short stature, when to start workup for puberty, and when induced IGF-1 was low, couldn't perform GS testing. So Dr. Adelaide, this is, I think, a case clearly of celiac disease. So let's give him time. And usually we will wait for 6 months to 1 year minimum. And once your weight increases, the height will start increasing, the puberty will kick in. One good marker will be bone age. So if your bone age is delayed, then you can wait. If, however, despite 1 year of good gluten-free diet, there is no improvement, you can then consider the possibility that there is also an associated GHD and we can work out for there. But I will wait till at least 1 year and look for bone age also as a marker in that regards. So we will now continue with our session, and this will be a Q&A session, and you have given answers also here.
Yes, sir.
Okay, so we have to get the
The answers will be in the next link, sir.
next. Okay, but how will we know about the people's answer?
So
If we maximize, will we be able to see it?
it will,
Yeah. Okay. So there will be Q&As, and what we want is that as soon as the question is coming, we request you to basically answer it in the Q&A, and we will have a look at it. Okay. Sure. Okay. So over to you, Dr. Sandeep.
Thank you very much, sir. So these questions sir has already discussed. This is just a brief revision about it. This is 13 years old boy at delayed puberty. Testicle volume is 3 cc and the pubic hair stage 1. Weight is 45. Height is 150. There were undetectable LHFHs. And MRI brain was done, which showed microadenoma. The boy was then followed up for the next 2 years, and there was a normal pubertal development. So, is this delayed puberty?
So anybody would like to answer? Is it delayed puberty? Yes. So Dr. Ravi, this is not delayed puberty. This was mislabeled as delayed puberty, as we discussed.
Were investigations warranted in this case? Extensive investigations warranted in this case?
So Dr. Aisha has already said, Dr. Ravi has said that they are not required. So this clearly is a case where unnecessary workup is done. We have messed up in this scenario. Yeah.
What was the significance of MRI finding in this case?
So there is a pituitary microadenoma which is there, and this is something which we often get, that there is a microadenoma. So do you think this microadenoma is causing delayed puberty? It cannot, because if you have a microadenoma, the only way it can cause delayed puberty is hyperprolactinemia. And that is very unlikely in this case. You need to have a very large lesion to really cause hypogonadism. So it's an incidentilloma. Next one.
Next question. This is 16 years old boy. He had delayed puberty. Testicle volume of 1 cc. Pubic hair stage 1. Height 138. Weight 28 kgs. LHFHs were low. MRI brain was normal. He usually used to have pain abdomen, and on examination he had anemia. There were high TTG levels, and biopsy was suggestive of villus atrophy. So what is the most likely diagnosis?
We've already given the diagnosis. So this is a classical case which we have discussed, that you have got a child who has delayed puberty. The clue here is that there is a short stature, there is failure to thrive, the pubic hair are absent. So this is classically celiac. So you have to think of celiac. I think everybody will be already have given the diagnosis there. Yeah.
What is the treatment? So treatment remains gluten-free diet lifelong.
Yeah, lifelong gluten-free diet will be recommended from that perspective. Okay. Yeah, carry on.
So this 16 years old boy, he had delayed puberty, testicle volume 1.
Yeah.
14 years old boy with delayed puberty, testicle volume 3, pH of 1, height 144, weight 36 kgs, bone age was 11, which was below the chronological age. LH and LFH, FHs were low, test was 23, and all the screening tests were normal. What are the most common DDs, likely DDs in this case?
So 14-year-old boy with short stature, otherwise the child is looking normal. So Dr. Aisha is saying this looks like a CDGP. Yeah, anybody else? Dr. Parag is also mentioning CDGP. So I think
this is most likely CDGP, and we have to differentiate with permanent HH. And GnRH stimulation and inhibin tests were performed, and GnRH levels were high. GnRH stimulated LH was high, more than 5, and inhibin was more than 50.
So this is the classical case of lack of pubarchy, short stature, and this is typical of CDGP, and inhibin B is the best test in that regards.
Diagnosis is CDGP. What is the management?
So how will you manage this boy? Usually we have discussed this in detail. You have to give a course of testosterone for 3 and then maybe up to 6 doses monthly.
15 years old boy, delayed puberty, testicle volume of 10, pH of 1, height is short. He has constipation, coarse skin, lethargy, cold intolerance.
So I think you can stop there. This is a very, very classical picture. There is a large testis, but no pubic hair, delayed puberty. So diagnosis here is, I think this is something which is quite easy to identify. Is hypothyroidism. Dr. Parag has mentioned, Dr. Aisha has mentioned, Dr. Ravi. So I think this is very, very clear. You have a short child who has hypothyroidism and you have no pubarchy because there is no adrenarche. So carry on.
And FHS were low, FT4 was low and TSH was very high. So the final diagnosis is hypothyroidism and treatment is levothyroxine. 15 years old boy, presented with delayed puberty, testicle volume 1, pubic hair stage 3, height is 160, weight 60 kgs, normal screening test, low LH, FHS, normal protein levels.
So hold on. So this child basically has got a relatively normal height for the parents. There is good pubic hair development. This makes CDGP less likely. So you should do a GnRH testing. How do you interpret this? Maybe we want to have the audience telling us the answer for this one. Permanent HH, Dr. Aisha, correct. So this is likely to be a permanent HH.
This patient also has anosmia and MRI head was suggestive of absent olfactory lobe. So the diagnosis is Kalman syndrome and the treatment remains.
You can give an option of giving the main advantage of identifying HH at this stage maybe to give a course of gonadotropins if you want to do it. Japanese society recommend that routinely you give gonadotropins and not testosterone. So you can think of that as an option.
17 years old boy, he has tall puberty. Initially, puberty starts at 12 age and there was no progress in the last 3 years. Testicle volume is 6 cc, just firm, height is 172, weight 55. He has gynecomastia.
So relatively tall for the family and you've got all the features, gynecomastia, stalled puberty. I think this is written everywhere. Dr. Ravi, Dr. Parag, everybody's talking about Klinefelter. Dr. Amar, Klinefelter syndrome. So this is a classical picture of Klinefelter syndrome.
Diagnosis Klinefelter syndrome and the karyotype is 47XXY most commonly.
The more the number of X chromosomes you have, the more likelihood that they will be having defect in terms of testis and the more tall they will have. Yeah. Carry on.
So these are true and false fact check. Delayed puberty is common in boys but less likely to be pathological than girls.
So is it true or false? I think this is the crux of what we talked about. So Dr. Ravi is saying yes, this is true. So this is quite clear, true.
Evaluation of delayed puberty in boys should be done at any age.
So it should be done at any age means you want to say what age, 1 year, 2 year also. So it should be done after the age of 14 years on. Yeah.
CDGP should be considered in boys with delayed puberty, compromised height and absent pubic hairs.
So I think this is very clear. So whether CDGP should be considered delayed puberty, compromised height, absent pubic hair. So Dr. Amar is saying yes. Dr. Aisha is saying yes. So I think this is very, very clear. The message is gone. Next.
Anosmia in boy with delayed puberty suggests Kalman syndrome.
Yes, again, a very important clinical sign. Anosmia, what are the other clues? So other clues could be synkinesia, they could be the dental anomalies, facial features. So Dr. Ravi, Dr. Aisha, both of them have mentioned this.
Post GnRH LH more than 5, inhibin more than 50, basal testo more than 20, SCG stimulator testo more than 200 suggests permanent HH.
Okay, so what do people think? No. So Dr. Parag is saying, Dr. Aisha is saying, I think this is clearly a suggestive of CDGP, not a permanent HH. Yeah.
Stalled puberty should raise the suspicion of intracranial lesions or Klinefelter syndrome.
Very important point. I am always more concerned about acquired short stature, acquired delayed puberty. Yes, this is a very, very sinister pathology. Carry on.
Low dose radiation causes delayed puberty.
Very good point. So low dose radiation causes delayed puberty. Again, interesting one. So Dr. Aisha said no, low dose radiation will actually cause precocious puberty. If the radiation is about 30 grays or something, you will start having delayed puberty. So Dr. Vignesh, Dr. Parag have also mentioned the same.
MRI should be advised in all cases of delayed puberty in boys.
So I think that's something which is debatable. So you should specify that you're talking about all cases, not hypogonadotropic hypogonadism. So only there's hypogonadotropic hypogonadism, MRI should be done. Next.
Klinefelter syndrome should be suspected if there is tall stature, gynecomastia, small firm testes.
I think that's what most people picked up. So Dr. Parag, Dr. Vignesh, everybody is saying yes.
Undescended testes with hypospadia in a boy with delayed puberty indicates file for erectus deficiency.
So that's an important point. So if you have hypospadia, you have a different ball game altogether. So Dr. Vignesh is saying yes. Dr. Aisha is saying yes. So you think of 5-alpha reductase versus androgen insensitivity syndrome.
Thank you.
Thank you. So thanks a lot, Dr. Sandeep, for really focusing us and bringing us this aspect. All of you can go and have a look at our website where a lot of publications are available, our app, which will help you in terms of evaluation and management, join our courses, and look at free resources in our website, which are there. So I think at the end of it, I'd like to thank all of you for patient hearing from joining us from across the globe. Thanks a lot, Dr. Sandeep, for presenting in such a nice manner and drafting some of these interesting questions. And we'll meet next month.